In the rhythm-controlled portfolio, you have drugs and you have ablation. Years ago, we made it clear, and I was part of this, I was on the initial guideline writing committees. The data on catheter ablation was in its early years. We didn't feel there were enough data to support as a first-line option. When we say first-line option, we don't mean you need to do an ablation. We mean it's part of your initial choice of therapies. But there are substantial data published now to, in my own opinion, and I think of many of the current guideline writers, that if you have a center that does good volume, good results with ablation, it should be in the mix, and it should be part of the initial discussion with the patient. So let's say, having said all that, the patient says, I like that, thanks Dr. P, I want to try that flecainide. That's fine. Have you flecainide? 3 months they come back in the office, how you doing? Well, I've been having a lot of episodes, and I'm already getting a little side effects, a little dizziness. I don't really want to go up on the dose. Well, then you have a choice to make. Either they stay miserable, which is to me not a good choice, but it is the patient's choice if they want. Usually that's not a choice. Let's try a different drug, or let's move on to ablation. If somebody comes back, let's take that same patient, and now every year I see them twice a year. They've been on 100 milligrams of flecainide twice a day, 0 side effects, feeling great. Now it's 3 years later, and they're coming to see me. I never tell the patient, you know what, you want to move on to an ablation. That is, to me, inappropriate. I'm not saying you couldn't do it. I always remind patients they still have another option if they so choose. And then if they say, well, is there a reason I should do it now? My answer is no. I mean, if a patient is tolerating a drug and it's effective, there is no reason that they have to go on to an ablation. I think ablation is a patient's choice more than a doctor's choice. That's a personal opinion. I always offer it. I mean, sometimes I will say, look, we're getting to a point where I think you need to consider ablation because your only choice is amiodarone, and you're 55 years old. Do I really want you taking amio for years? Not really. I think that the better choice there for you is to consider an ablation. So ablation can be upfront. I have a patient recently who saw me who's an athlete. Now, I'll promise you, athlete is not going to take drugs, okay? End of story. They never take drugs. They don't want beta blockers. They don't want any drugs. I mean, even anticoagulants are a struggle with athletes. And they sure as heck don't want antiarrhythmic drugs. I mean, his rate in my office was 45. Okay, he's fine. Any drug I give him is going to lower it, and he's set up for an ablation. There's no question. Those kind of folks just need right to the ablation lab. So I think it's an individual thing. But if you're not doing well on the drug, either effectiveness or side effects, move on to ablation. That, I think, is an easy path for a patient. If you're doing great with no side effects and great efficacy, if you want to get off a drug and take an ablation, fine. If you don't, then don't. I think there's no compelling reason to do an ablation.